Hello, my name is Megan Morris, and the title of my talk today is Using Implementation Science to Advance Health Care Equity for Persons with Disabilities. The competencies that are covered in this presentation include implementation and improvement sciences. So there is a relatively new body of literature, although it's growing every day, that demonstrates that individuals with disabilities experience significant health and healthcare disparities. So today I've just provided a few examples. Again, there's a much larger literature base about this topic, but again, here's a few examples. Women with physical or cognitive disability have decreased rates of cancer screenings and preventative conversations. Patients with communication disabilities are 3 times more likely to experience an adverse medical event when they are hospitalized as compared to individuals without disabilities. Additionally, patients with communication disabilities report low satisfaction with the quality of care they receive. And my final example is that patients with physical disabilities are less likely to receive evidence-based treatment for early stage lung cancer. You may or may not be aware that there is a legal requirement for healthcare organizations to provide accessible healthcare to individuals with disabilities. We have the Rehab Act of 1973, the Americans with Disabilities Act of 1990, and most recently, the Affordable Care Act of 2010. And I would like to highlight specifically Section 1557 of the Affordable Care Act, which states that healthcare organizations are required to provide effective communication, which includes provision of auxiliary aids and services such as hearing assistive devices. Additionally, they're required to establish accessibility standards for buildings and facilities and health programs provided through electronic and information technology systems. And finally, healthcare organizations are required to make reasonable modifications to policies, procedures, and practices to provide patients with disabilities access to organizations, health programs, and activities. In order for healthcare organizations to do this, they need to be documenting who has a disability. So there's 2 main reasons for this. So first, healthcare organizations need to systematically and consistently document who has a disability so they can identify who requires and needs healthcare accommodations. We have additional policy statements about this topic, including a Joint Commission report of 2010 that states that healthcare organizations need to be documenting patients' mobility and communication needs in order to provide patient-centered care. Additionally, the Department of Justice, in response to the ADA, states that healthcare organizations need to be documenting disability status in order to ensure that they're providing their patients effective communication. And then finally, healthcare organizations need to be consistently and accurately documenting who has a disability so that they are able to track the quality of care delivered to individuals with disabilities at the organization level. And we have Section 4302 of the Affordable Care Act that actually requires healthcare organizations to be documenting race and ethnicity, primary language, and disability status for the purpose of tracking disparities. In response to these policies, and again, the identified need for documenting patients' disability status, we've done a series of research studies on the topic. I'll just briefly go through these studies because for the most of this presentation, I would like to focus on one of our studies. Okay, so first we identified that disability status was not easily ascertained using diagnosis codes in the electronic health record. Next, we conducted qualitative interviews and conducted a survey with patients with and without disabilities and found that patients almost universally reported little concern with reporting their disability status to healthcare organizations. They were most concerned or interested in knowing how healthcare organizations were going to use the data. Next, we engaged diverse stakeholders, including patients with a wide range of disabilities, providers, and then other national stakeholders, including policymakers and researchers, to identify the disability status questions that are best to be used by healthcare organizations, again, for these two purposes: for identifying patients who require accommodations, and for organizations to track the quality of care delivered to patients with disabilities. And lastly, we have conducted qualitative interviews with healthcare organizations nationally, and have found that organizations are really struggling with how to implement the collection of disability status. So this leads us to our next research study that I'll talk about. So implementation of collection of disability status during patient registration. So I'm currently at the University of Colorado, and as a part of the University of Colorado Health System, which is called UCH, we conducted a study on how to implement collection of disability status. So our research question was, how do we implement collection within a large healthcare organization? We conducted a mixed methods implementation trial, and we used the LeaRRning framework to guide our implementation and evaluation. As I mentioned, this was conducted at UCHealth. We specifically focused on conducting it within the primary care setting. At the time of the study, this included 53 primary care clinics that spanned all over Colorado and into Wyoming and Nebraska. UCHealth uses Epic, and prior to this study, we had worked to include the disability status questions within the EHR. So it was already established before we were starting the study. Our plan was to integrate the collection of disability status during new patient registration. And at UCHealth, new patient registration was done through a centralized scheduling office, which is called Patient Line. And at the time of the study, there were 94 agents, Patient Line agents, who conducted the new patient registration for all of these primary care clinics. As I mentioned, we already had some disability questions in Epic, our electronic health record. And really briefly, these are our categories. So we had a question around hearing disability, vision disability, cognition, mobility, activities of daily living, and fine motor, and then finally a communication question. We additionally asked a general screener question that stated, due to a disability, do you need any additional assistance or accommodations during your visit? And I'll just note, these are the questions we identified in the previous study where we engaged national stakeholders. They're also, the first 6 questions are also very similar to national questions, specifically the census questions, as well as the Washington group questions, which is a group that is part of the UN that looks at disability statistics internationally. So prior to our intervention, our data collection period, we conducted a 30-minute training with our patient line agents. This training was developed for the study, and we included frequently asked questions. We had some videos, some different scenarios. We talked about disability etiquette, and also, of course, the importance of why we were collecting the information. We additionally provided the patient line agents written materials, including a paper tent, which they sat on their desk, that included a prompt for that would go before the questions to explain why the questions were being asked, as well as frequently asked questions that the patients might ask, as well as answers to those questions. And then during our intervention period, which was 6 weeks, we sent reminder emails every 3 weeks, so halfway through, at the beginning and then halfway through. So in the study, we engaged diverse stakeholders. So in planning for the study, we included UCHealth's ADA coordinators, patient line VP and employees. We also engaged primary care clinics and providers, as well as ambulatory care leadership. And then finally, we included patients and caregivers with persons with disabilities. And what we found was that our institutional stakeholders, primarily those who were involved in the healthcare system, they stated that one of their main priorities for documentation of disability status was really the length of time that the questions would take. Patient line, our registration center, their main metric was how quick their call times were. And so there were concerns about asking this series of questions and how much time it would take and add to the calls. And so because of this, we somewhat adapted our study design. And in those, again, we had our 6-week data collection period. In the first 6 weeks, what we did was we had the patient line agents ask all of the questions. So the 6 different categories of disabilities, as well as the screener question, as well. So that was the first 3 weeks. And then the second 3 weeks, we flipped it. So we had the patient line agents ask the screener question first, and then followed that by, if a patient answered affirmatively, asking the full set of disability questions. Next, there were concerns that patients would be offended and there would be patient complaints. So we made sure in our data collection that we were looking at patient complaints as well as conducting interviews with patients to understand their perspectives of collecting disability status. As I mentioned, we used LeaRRning for identifying our outcomes. So first was reach, which we defined as the percentage of patients who had no disability reported in their EHR, one of the disability categories reported, or decline. And this is comparing to the field being left blank or other being reported. And we gathered this data through our electronic data warehouse. We were not collecting effectiveness data as this was an implementation trial. For adoption, we reviewed recorded calls and reviewed the patient line data of completion rate by agent to look at whether or not the patient line agents were asking the disability questions. For our implementation outcomes, we conducted focus groups of our agents, interviews with patients, and we also again reviewed the recorded calls to understand how data collection was actually happening. And then finally, with maintenance, we gathered maintenance data through our focus groups of agents, as well as reviewing our Compass data. So Compass was our electronic data warehouse, looking at the EHR data. So on to our results. So first, in our 6-week data collection period, there were 3,673 new patient registrations across our 53 primary care clinics. And we found on average across all of those, the whole 6 weeks of data collection, that the completion rate was 45.9%. Prior to our implementing our study, the completion rate was less than 10%. And by week 5, which was maintained into week 6, it was almost over half of the new patient registration, so 52.9%. And then again, we looked at maintenance 8 weeks post our 6-week data collection period and found that the patient line agents maintained collection at, again, around that 53%. Next, looking at adoption, 46 of our 94 agents, so almost half of our agents participated in in-person training. The other agents were given access to the training through the agents had a online education platform or portal, which we posted all of our education materials there. So they had access to that. And what we found was that actually it was significant that those who participated in our training and the in-person live training had higher completion rates than the agents who, again, were just given access to the training through the education portal. And we don't know, again, if they reviewed or did not review the training materials. Moving on to implementation, we reviewed 112 calls. And about 54% of the calls we observed, the patient line agents did ask the disability status questions. Of those 61 calls, only in one of those calls did a patient ask why the questions were being asked. And again, we provided the agents with frequently asked questions and responses, so the patient was able to read the response of why the questions were being asked. As I previously mentioned, our institutional stakeholders, their main priority was the length of the calls and how much time asking these disability questions added to the calls. And what we found in our, again, first period where we were asking all 7 questions, it increased the average call time by 56 seconds, whereas our second phase of the study, where we were asking the screener question, followed by the full 6 questions, this increased the length of time on average 18 seconds. And it's also important to note that we found similar rates of reported disability in the 2 phases. So we did feel comfortable at the end of the study recommending the screener question, followed by the full set of 6 disability categories if a patient answered, again, the screener question affirmatively. We did find that when the patient line agents did ask the questions, they deviated from the script or prompt over half of the time. Again, we conducted interviews with patients, and it was very interesting. We would call the patients and say, hey, you were asked these disability questions during your call, your new patient registration call, and patients universally said, I don't even remember being asked these questions. And they said, of course, I assumed my healthcare organization would ask me questions about my disability status because they needed to know this information in order to provide good quality care to me. So really, again, our institutional stakeholders had concerns about how patients responded. And in our qualitative interviews, patients really had no issues. It's also important to know during our data collection period, which again was in about 1,600 of the calls, the disability status questions were asked, and there were no patient complaints during this period. And then we conducted also focus groups with the patient line agents. Some of the agents still expressed discomfort in asking the questions. They just felt as though they needed more time to become comfortable with language around disability and how to talk to patients about disability. There was some confusion about where the disability fields were located in EPIC and where they were supposed to input the information. So that cued us in that we needed more training and some standardization in that process. Participants, the agents stated that sometimes they forgot to ask the question, which prompted a question amongst our institutional stakeholders about what additional prompts we could put within the EHR. There was what's called a registration wizard to remind agents to ask these questions. And then the patient line agents, some thought that perhaps the clinics should be asking the questions. And while we heard this comment, we will say that one of the reasons why we focus on collecting disability status with our patient line agents was that healthcare organizations, again, remember one of the main reasons for collecting disability status was to identify patients who required accommodations. And it's best to know as much in advance whether or not an accommodation is needed so that when the patient arrives for their clinical appointment, that accommodation is available for the patient, rather than, again, asking during the clinic visit if the patient needs an accommodation and then scrambling to try to find that accommodation and make sure the patient has that during their clinical visit. And then finally, maintenance. In our patient line focus groups, agents reported a willingness to continue to ask and collect disability status. And then, as I mentioned, our completion rate remained constant at, again, a little over 50% at 8 weeks following the trial. In the meantime, while we were conducting the study. And since this study, we developed what is called the Disability Equity Collaborative. As I was doing this research, I started getting calls from health systems asking for advice on how they should implement collection of disability status in their organization. And, you know, there's not a whole lot of data in this area. I presented this implementation trial, but it was a pilot study, and there's still much to learn about how we collect disability status. And so to address the stakeholders' immediate needs and concerns, we developed this Disability Equity Collaborative, and we got stakeholders together. So not only our healthcare organizations, but our policymakers, our researchers, our healthcare providers, our patients, etc., our also insurance providers, and our EHR vendors. And as a part of our Disability Equity Collaborative, here's our website if you're interested in learning more about it. We have 4 work groups, and one of our work groups you can see on the bottom left-hand side is documentation of disability status. So this is a work group that we get together quarterly, and we discuss, again, how we can advance policies and practices for systematic collection of disability status in the electronic health record. I just want to briefly mention our other work groups. We have our practice work group, which we call our DEC leaders. And these are, again, healthcare organizations who are working on the front lines of implementing accessible care in their organizations. That group meets twice a month, and it's an opportunity for individuals in these healthcare organizations to get together and say, hey, I ran into this challenge this week. Has anyone figured out a solution to this? Or celebrate their successes of we were able to implement this new initiative and have these great results. We also have a research work group where we sponsor quarterly presentations. And then our final work group is our guidelines for implementing accessible care. As I mentioned, our disability status work group has diverse stakeholders, and we collaboratively develop standards for how to document patients' disability status. This last year, we actually saw some movement in policy. So specifically, the Office for the National Coordinator for Health Information Technology, which is also called ONC, they were considering inclusion of disability status as a standard data element. And what this would mean was it would require all electronic health records in the United States to include disability status as a standard data element. So as in part due to our Disability Equity Collaborative work group, I was invited to speak with the committee that was considering this data element and share the data that we have developed through multiple research studies, as well as the voices of our stakeholders, again, our healthcare organizations that are actively working on this, as well as other different patient stakeholders, policymakers, etc. And last July, they did put out their newest, ONC put out their newest standards for data elements and did include disability status as a standardized data element. In response to this, this last fall, our Disability Equity Collaborative Documenting Disability work group produced an implementation guide called Documenting Disability Status in the Electronic Health Record. And this is available on our website. Anyone can go on and have access to this. And this is a document of really just outlining all of the data we've collected, the research, but as well as understanding what is currently happening in health systems and sort of a current best practices for documenting disability status. So that concludes our presentation for today. So hopefully you learned a little bit about documenting disability status and how we used implementation science, as well as engaging diverse stakeholders to advance both the practice, but also policy that will hopefully lead to improved health and healthcare outcomes for individuals with disabilities.